we're going to have an opportunity to hear you talk to each other after having listened a little bit to each other. I don't know whether you withheld questions during the formal presentation and you want to ask a question now. But we had a chance to think about individuals and their experiences, some of the diverse contexts in which people experience substance use challenges, and some of the care strategies, including some really innovative and specialized care strategies to address some of these issues. But what we also heard about over and over again were the challenges that our silos are presenting in terms of the care provided to individuals who have complex and diverse needs. So I just wonder, in terms of our thinking about those social determinants and multiply complex needs, what else we could be doing to try and provide care in holistic ways. And I think I'm going to ask Jasleen to start that response because you first identified it.
So I think I can only really speak to kind of what I did and what I think has worked for a lot of the folks that I work with is that we have to evaluate kind of our role in our patients' lives. So I work at a clinic where I know patients will come to see me because they need their Suboxone or they need their methadone. And so I knew I was an access point that a lot of people access because they need their medication. And so I took that as an opportunity to say, okay, well, I know these folks don't get primary care because going to their primary care provider can be super stigmatizing. So I started to do primary care there, and then I started to do referrals, and then I took training in therapy, and now I do therapy with my patients because I recognized that I was part of a system that was propagating these, these problematic silos. And so I basically tailored my own practice in a way that I felt like I could say I was actually working in a meaningful way with the people I work with. But I think for folks who are maybe not working in that context, I think a first step really is to have a look at the institution you work with. Look, it kind of starts big picture to small picture. So look at your environment. What environment are you fostering? Are you putting up images that promote inclusivity, or are you putting up images that propagate kind of further siloing? Are we as primary care providers, for one thing, we should integrate like trauma and substance use screening in all our intakes because we know that women actually feel further isolated from healthcare providers if they actually don't even screen for trauma. So one of the things they can do is actually change the way that they kind of integrate it into all their care and not just somebody who they look at and identify as somebody who may potentially be using substances.
Well, I think that that's a provocative question. Should there be routine universal screening for trauma and for substance use? What would you, Tim or Faith, what would you think about something like that?
Go for it. You want me? I think in theory, yes. I think it's largely contextual. I got asked this question on another panel a couple of months ago. I can't remember. I think that theoretically, yes, there should be a level of competence in a number of areas. My concern, and when I imagine myself engaging with my own family physician on those particular topics, I don't think that those are questions that I would personally answer honestly. So I mean, I think it's a question of, do you ask those questions? Again, theoretically, yes, it's probably a good idea because there seems to be so much emphasis in directing folks to primary care. I think it's also important to think about the context in which those questions are being asked, right? I mean, are we creating an environment in which folks feel that they're able to answer honestly? I think my family doctor is a lovely man. I would not talk to him about my trauma because I think that is beyond the scope of his current practice. So presumably he would need a lot of support and training in order to be able to do those things well.
Does anyone else want to comment on the notion of screening and its pros and cons?
I think that a lot of practices that we hope would be applied universally and applied evenly unfortunately, in theory, work well, and then in practice are not applied in a uniform fashion to all groups and individuals, unfortunately, in the world that we live in. So I think that the concept of universal screening could be very destigmatizing if we then acknowledge how widespread trauma is, how widespread experiences of violence are for people on the kind of feminine spectrum when it comes to gendered experiences of violence. Unfortunately, I think that some individuals would adopt that practice universally, and others would assume that they know who they need to apply it to.
I really appreciate your comment because I think one of the thing as a family doctor that I think there's a lot of fear among colleagues that they won't be able to respond appropriately to if somebody discloses trauma. And I know a lot of folks that I work with who tell me what they experience, but they don't tell their family doctor. And so when I think that I agree that universal screening could be really destigmatizing, but I think an acknowledgement before screening is way more important. So saying, because I always contextualize it in like, we need to learn how to trust each other before we can have a meaningful relationship, and at any point know that this can be something we talk about. So I actually don't necessarily screen everybody, but I integrate it into my intake as when you feel ready, if that's ever, and it's okay if it's not, just be aware that that's something we can explore, because if you really do adopt trauma and violence aware values, then really what you need to just do is be empathetic and free of judgment. And there's a difference in being trauma aware and providing trauma specific services. So I wouldn't even begin to say like I'm a trauma therapist, but I think I can be trauma aware so that I can help the client in front of me navigate in a way that's meaningful for them.
Thank you. So, Mel, as an addiction medicine practitioner, would you think that screening for substance use or substance dependencies would be a good practice in primary care settings?
Hello? It works? Absolutely. I mean, I think that especially if you're a physician and you're prescribing opiates, as most doctors are, you have to be able to screen and identify opiate use disorder. Alcohol use disorder, there's still, despite the opiate crisis, there's still more people dying from alcohols than from opiates, and they have to be able to screen. And the reason why it's so important to screen is because we have effective treatments available. And the primary care system has far greater capacity than all of the addiction treatment system combined. When you look at the numbers and so on, Ontario has put billions of dollars into specific primary care facilities like community health centers and family health teams with the specific mandate to look after patients with mental illness and addiction, marginalized patients. And yet they're not getting involved in addiction. And I think this is a problem. There's no question that there should be universal screening. The problem is that a lot of doctors and nurses and so on, nurse practitioners, don't know what to do with the patient once they've identified a problem.
Thank you. Tara?
I guess I would add to that, in some of the conversations we had in the last little while, was that it can be concerning how that screening is used. So there are people who have an opioid use disorder or who have trauma who, if they're screened in that way, are then told, I can't handle you, I can't take you on. And we heard that over and over, that, an example was a person who had chronic pain and had used opioids in the past and lost their doctor, who moved out of province, and they found another doctor who was accepting patients, and they did a screening questionnaire with them, and they said they'd used opioids, and they said, sorry, canceling your appointment, won't take you. And that's what and Mel, you alluded to that before with where some of the prescribing community is going with opioids around cutting off or refusing to prescribe them. And there's always that balance with screening where we could run into the situation where it's actually used to further stigmatize among certain clinicians. So I think we have to figure out how to balance that as well. And when you say universal, then suddenly it gives a tool to people to refuse care as well.
I think that's a really important point. Thank you for bringing that forward. I read that Portugal, just to move from local to sort of international, I read that Portugal decriminalized everything from cannabis to crack in about the year 2000, with a resulting drop of 50% in their addiction rates. So do you think that kind of a strategy would work in a place like Canada? And what would be the arguments for and against it?
Well, I think that the problem that we're facing now is very much related to fentanyl. Fentanyl is a powdered opiate that is 100 times more potent than morphine. It's manufactured in China and shipped over from Mexico. Powdered fentanyl will never be legalized, ever. I don't think there's a problem with accessing legal opiates. So I don't really see how in the opiate crisis that simple legalization of fentanyl or heroin is going to make a difference. What is important is that people who are drug users feel that there is no that they don't have to fear the police or being charged. They should be able to call if they have a friend who's had an overdose without worry that the police will arrest them. I think it's ridiculous to put people in jail for mere possession of heroin or fentanyl. I'm fine with the big drug dealers going to jail forever, but I think that there has to be reasonable, laws. And the other thing about prisons is that they're filled with people who are opiate users who have to commit crimes in order to maintain their habit and to avoid withdrawal. So they commit crimes every day, of break and entering and prostitution and drug dealing. These people shouldn't be in prison. If they are in prison, they should be given access to methadone or buprenorphine treatment, which they aren't right now.
I mean, I think for me, it's not even a question of whether or not decriminalization works. It does. I've not, admittedly, I'm not the most well-read on these subjects because everything has a paywall, but I'm not aware of, any study anywhere ever that said decriminalization has negative health impacts. That's just not a thing that is a thing at all. And I think if you look at the specific example of Portugal, this was pre-fentanyl, admittedly, so you can talk about how transferable these health impacts were, but their rate of new HIV infections, of overdoses, both fatal and non-fatal, went down substantially. They, at one point, when they began this process of decriminalization, had rates of HIV infection and of overdose deaths that were, I think, higher than a lot of other European countries. Now they have, I think, one of the lowest rates for both of those things anywhere in Europe. Their rates of substance use, generally speaking, and particularly amongst youth, are also lower than the European average, and these are all things that have happened since decriminalization. I think what's unique about Portugal is they took the money that they had been putting towards criminalizing substance users and they put those resources into supports for substance users. So decriminalization in isolation is harm reduction in practice and would certainly help, but why Portugal has been so successful is because they reallocated resources.
Do you want to go first, or?
No, go for it.
Okay. I'm both in favor of decriminalization and legalization at the same time. I think that legalization is helpful so that regulation of an actual drug, people know what they're getting and people know what the purity and the actual content of the drug that they're using. And at the same time, being able to give back autonomy to actual drug users and substance users is important, and that's a big value of harm reduction. At the same time, what we're seeing through the legalization of marijuana right now is that I kind of see the legalization process right now is pretty racist and colonialist because you have an underground economy right now that's already existed, and a lot of the people that are dealing weed right now are from black communities and are from people that are highly criminalized at the same time. So those people are actually losing a lot of their sources of income to be able to support themselves and to support their own communities at the same time. And meanwhile, a lot of the people that are starting up the storefront dispensaries or the people that are going to be involved with the pharmaceutical companies or the production companies regulating marijuana probably aren't going to hire a lot of the people that are from these like black communities that are already doing this type of work right now. So, and a lot of those people already have charges on them or might already be incarcerated, but they're not going to get any sort of, I guess, like absolution of like their charges or like they're being like an inmate or anything like that. So I think it's really important to like really look at decriminalization and legalization through an anti-racist and anti-colonial perspective as well.
Thank you. Tara, did you want to say something?
I think both of you have summed up kind of what I was going to say very well. So I don't think I have much to add except that I do think the Portugal model, the big value of that was the redirection of funds that sometimes people don't think about. They just talk about, you know, the decriminalization and not what they actually did with the funds that they saved. And I think that that's important. They also didn't have great access to addiction treatment at all in Portugal beforehand. So there was also a huge change from having very little access to treatment to a lot, which I think also helped drive the pattern. So I don't know whether that model will have the same impact here. But on the kind of decriminalization, legalization front, I think where I land on that is figuring out how we can get a safe source of drugs for people, because methadone and Suboxone are good options for people who are wanting to engage in treatment. But there are people where methadone and Suboxone aren't right for them, and they would feel much happier if they could get their stable, dependable source of hydromorphone or heroin that they knew was not contaminated, and that they knew that they have been self-regulating on that for the past 20 years. And if I could just make sure that it wasn't contaminated with fentanyl, I could manage in my life consistently that way. So I think we need to think about how we can provide safer alternatives for people as well as methadone and Suboxone, and not have this stigma that any kind of illicit opioid use is bad unless you enter into treatment. I do think there has to be some additional thought into other alternatives as well.
Thank you. I do have one last question for you, which is if you are the friend, partner, parent, or child of someone who you believe has a substance use dependency or substance use problem, what is the best approach or best thing to say to that individual?
I don't know if I have like the statement, but I think when we talk about substance use and we talk about who's most affected and we talk about solutions, there is this professionalization, credentialization that is happening that is really blocking the voices that need to be heard. I think even though there are reasons why these things are put in place, for me, like how I talked about semi-merit programming, I understand my whiteness. So instead of saying, I know what supports and services people need, and I'm going to put them in place, and then we'll find out if they're effective, whether you show up or not, I don't think that's the way it needs to go. I think that we need the peer voices, we need the lived experience to start informing the work. That's the most important aspect of harm reduction for me. And I think so often when people come to people with substance use, it's such a taboo topic, that people automatically tell you what you need, what you should be doing, without really knowing what your options are. And I think it's time that we listen to people when they speak their truths. I think we need to respect those truths. And I think we need to inform these policies, procedures, programs. I say we do nothing without that voice and without those truths, because really we can't inform that based on our stigma, our assumptions, and our own lived experiences. I think collectively we need to put the problem in the hands of the people most affected, and we need to start trusting them that they know what's best as opposed to what us as professionals knows is best.
Anyone want to say anything beyond that?
Excuse my rant.
Well, so as an addiction doctor, I see people who want treatment. I mean, they come for treatment. So that's different than maybe somebody who is continuing to use and feels that's important for their lives. What I think in talking to people who are treatment seeking is to talk, first of all, about what substance use disorders is. Because so many patients, especially in my experience, women, but I think a lot of patients, they feel unbelievable guilt. They feel guilt and shame that they're using, and even though a lot of them are using to cope with a very difficult social situation, they have reasons for using, such as post-traumatic stress disorder. They're not hurting anybody with their use other than themselves, and sometimes they're having enormous social obligations, looking after elderly parents, looking after children, having an abusive husband, etc., and yet they still feel guilt. There's something wrong with me because I'm still using. So we talk a lot about what is addiction and the biological aspect of it, as well as the psychological and social determinants of it. And then we talk about treatment options, recognizing that there's no one absolute way to go. One of the terrible things about addiction treatment now is it's so cookie cutter. You go to this and you get this. You go to another place and you get this. So people need to know, here's the various options. And, it's not your fault that you're addicted, but, if you want help, it's going to take some work, and well, let's try this, and if that doesn't work, you can try something else. So you want people to leave after that first visit with a sense of, geez, that burden of shame being lifted and some sense of optimism that they can get better.
I think that some of what you've just said goes beyond the addiction medicine-doctor relationship, and we can take and extract some of those same qualities, introduce them into personal relationships. So with that, I want to thank you all so much for participating this afternoon.